Hello, everyone. My name is Kay Gooch, and I'm Director of Community Programs here at ARC. And I'd like to welcome you to our February webinar on Amyloidosis 101. So I'm going to move us to the next slide here. For a little background on ARC. ARC is a patient-focused, patient-founded nonprofit whose mission is to advance science to both improve and extend the lives of those with amyloidosis. And so we have four different areas that we focus on. We focus on improving the speed and accuracy of diagnosis, and then increasing our understanding of the disease to identify new treatments, accelerate the approval and reimbursement of effective treatments, and then also to enhance the care and quality of life for patients and care partners. I'd also like to take a moment to just thank our sponsors today, who have sponsored and making ARC webinars available, and a big thanks to them in support for this webinar series. And just a little bit of housekeeping. At the end of the webinar, you will receive a survey from us. And so please take a few moments to fill out that survey, and that will help us plan future webinars. Also, the webinar is being recorded, and it will be on ARC's website for viewing in the next few days, so you will be able to see it again. And as we go along, we'll have our presentation first, and then we will have time afterwards for questions and answers. So if you would like to, along the way, just go ahead and put your questions in the Q&A box, and we'll have time at the end to do that. So now I'd like to move forward to introduce you to our presenter today, who is Dr. Sarah Cuddy, and we're so glad to have her with us. Dr. Cuddy is a cardiologist and co-director at the Brigham and Women's Hospital Amyloidosis Program in Boston. She is an assistant professor of medicine at Harvard Medical School. She completed her medical school, residency, and general cardiology fellowship in Ireland. She then trained in multimodality cardiovascular imaging at Brigham and Women's under the supervision of Dr. Sharmila Dorbala. Inspired by her work in cardiac amyloidosis, Sarah joined the program as a fellow in 2018, and then she joined as faculty in 2020. Her research to date has focused on multimodality imaging in cardiac amyloidosis. She's published several important papers on imaging, and is also co-investigator and site PA for several therapeutic trials in ATTR amyloidosis. And her future goal, which I find very interesting, is to address exercise intolerance in cardiac amyloidosis. She's received career development awards from the American Heart Association and the NIH to evaluate exercise training in patients with cardiac amyloidosis. She's an internationally recognized expert in the field and has written, editorials for top cardiovascular medical journal. And so we are so excited to have you with us today, Dr. Cuddy, and I will turn it over to you.
Yeah, thanks a million for inviting me here today and for that introduction. I'm going to start sharing my screen. Oh, someone else is sharing. So I think once you stop sharing, I can share.
There we go.
Okay, super. And here we go. So hopefully now you can all see my slides. So Amyloidosis 101 was the talk I was asked to give today. So I'm going to try and keep this as basic as possible. So if you come away from this saying it was a little bit basic, well, this is my warning. That was my aim. If you come away and say, I didn't really get it, please write down your questions, because we're here to answer the basics, or I'm here to answer the basics. So I want to make kind of sure that we cover basic principles and really get into kind of the whole mechanisms behind it to help you kind of understand what amyloidosis is. So these are my disclosures. As I said, I've got a few grants, and also I've been involved in so many different clinical trials in amyloidosis, which has been really exciting over the last few years. So like I said, I want to give an overview of amyloid. I'm going to go into the types, the organ involvement, some of the aspects of making the diagnosis, and then also the principles of treatment. So amyloid or amyloidosis is a group of complex diseases caused by protein misfolding. So you're going to hear me say that over and over again. the protein misfolding. And then these misfolded proteins get aggregated into highly ordered amyloid fibrils. So we're going to take a look at what that looks like under the microscope. They then deposit in tissues and organs, resulting in progressive organ damage. This can be localized in some cases, where it just seems to be in one organ or one kind of mass. That can sometimes be tricky for us because we have to make sure that it's not involving any other organ or tissues in the body to make sure it is just localized. Then there's systemic amyloid. And when we talk about systemic amyloid, we mean that it can affect kind of a very important organ like the heart or the liver or the kidneys or multiple organs. So we have thousands of different proteins in our body. They do so many different things. They all have important roles. Some of them we don't think are absolutely vital, kind of like our appendix. We could probably do without them because there might be another 2 or 3 other proteins that do a similar job. And some of them are absolutely essential in kind of the functions of our body. So this is kind of the key. Whatever the protein that misfolds and forms the amyloid, that's how we name the amyloid. So in transthyretin amyloid, ATTR, it's called transthyretin amyloidosis. In light chain amyloid, we have light chains that cause the amyloidosis, so we call it light chain amyloidosis. Reactive systemic amyloidosis still kind of gets called by its older name because that's more caused by serum amyloid A protein, and that's related to chronic disease. So when we have chronic inflammatory conditions, you can get kind of overproduction of this serum amyloid A protein, which then misfolds. And here I've got a little cartoon of what the fibrils look like. They're kind of all these proteins that have aggregated together to make the amyloid. And I'll show a lot more kind of demonstrations of this. So again, this is what we have, a normal folded protein. So a normal protein, and this can usually in amyloid, it's in the bloodstream for some reason. So it's kind of moving around, circulating in our body, and it misfolds. And in some cases, we don't really understand why it starts to misfold. In others, maybe it might be due to a genetic mutation, but that's not always the case. Sometimes it will just happen for reasons we don't fully understand. These misfolded proteins then start to clump together or aggregate. And when they aggregate together and form these kind of very well formed sheets we call beta pleated sheets that get into these fibril formation that can get it into different tissues in the body, as I said. So if we think of transthyretin amyloidosis, this is an example of the transthyretin protein, the TTR protein. It's predominantly made by the liver. 95% of this protein that's in our circulation is made by the liver. It can also be made in small amounts in our brain or in our eyes, but 95% is made by the liver. And it gets into the bloodstream. It helps transport thyroid hormone and vitamin A. So that's where it gets its name. Trans for transport, Thy for thyroid, and retin for retinol, which is vitamin A. And it's actually retinol binding protein. So another protein that binds. You can just see how complex the human system is and how much we rely on different proteins for different tasks. So as I mentioned, this is one of these funny ones where it's not the only protein that can help transport thyroid hormones around the body. Hence, we don't think it's absolutely necessary in our circulation. But it's a protein that's in everybody's circulation. And we can measure it in the lab, how much of it. It used to be called prealbumin. So sometimes when we do a blood test, we can measure prealbumin levels. So this is in what we call a tetramer. So it's 4 subunits that are pretty much identical linked together. The problem occurs when these dissociate or break apart into individual components. So these kind of dissociate apart and break into individual components. And then they misfold, as we saw in the prior cartoon, and they start to clump together, making something called oligomers. And then the more they clump together, we get amyloid fibrils. And in transthyretin ATTR, we know that these in some patients can involve the tendons and ligaments. Here's a bicep muscle, and here's the tendon that attaches the bicep muscle to the bone to help us flex our muscles. Sometimes the amyloid can get in here and cause this to snap. So some people will have a biceps tendon rupture where this clumps up and gives you like a Popeye muscle. It can also get into the tendons in the wrist and cause carpal tunnel syndrome, or the ligament in your spine and cause spinal stenosis. And that can compress the nerves either that are traveling through the carpal tunnel or traveling through the spine and cause a compressive neuropathy. We also can see in the genetic form of the disease, it can actually directly involve the nerves. And this is mainly the peripheral nerves. So the nerves that kind of go into our peripheral muscles to help move our hands, our feet, our legs, our arms, and also give sensation, pain, temperature, heat. So if it involves the nerves, people can get numbness and tingling in their hands and feet in what we call often a sock and glove distribution that gradually progresses and goes further and further up the arms and legs. It can also involve our other nervous system called the autonomic nervous system, which is our flight and fight response, which I'll go into later. And then, importantly, what we worry about and what I worry about as a cardiologist is when it gets into the heart and causes a cardiomyopathy. And we'll get into more detail on that in a little while. So that's TTR. Light chain amyloidosis is a whole different process. Okay, so in light chain amyloidosis, we all have plasma cells in our bone marrow. So plasma cells help make antibodies, and we know we have antibodies to help fight infection. What can happen here is the plasma cells start to make too much of one component of the light chain, of the antibody, the light chain component. So our antibodies are made up of heavy chains, these longer blue, I hope you're seeing my mouse, lines, and then the smaller pink ones that are called light chains. And the light chains can be either called kappa or lambda. So what can happen here is the plasma cell can start to make too much of kappa or lambda. And again, we see the same process happening. The protein starts to misfold and clump together and make the amyloid. And then this clumps together, making the amyloid fibrils. Again, that can get into different organs and tissues in the body, causing them to dysfunction. So we'll take a closer look at this, okay? On how to help visualize what this looks like. So if any of you've come to my clinic, I sometimes say I think amyloid fibrils look like little bits of fiberglass that get deposited. So this is a sample. This is muscle cells here. And all this material in here is amyloid that shouldn't be there, okay? So you can imagine the more and more as that builds up around, it constricts how well the muscle can relax and contract. And that's what I always think of in the heart. Our heart is a large muscle. So as this material builds up around these muscle cells, they're not going to be able to squeeze and relax as well as they should. So here it is in higher power. So this is why I say I think these are all these little fibrils that are getting into the tissue around the cells. We call it extracellular infiltration or deposition. So you can see all these tiny individual fibrils are all building up. And this is what amyloid looks like when it gets into different organs and tissues. Okay, again, this is a very zoomed out picture of a muscle. Okay, and when we zoom in, here is a blood vessel that's supplying the muscle with oxygen. There's like red cells inside it. All surrounding, in this patient's case, their blood vessel is lots and lots of these amyloid fibrils. Okay, so imagine this. You're walking, you're running, you're trying to do something. Your muscle needs more oxygen, but your blood vessels are surrounded by the amyloid. It's harder for the oxygen to get into the cells that need it. Hence, you can have exercise intolerance, more fatigue, shortness of breath. Just find that maybe your muscles aren't able to do as much. That's kind of the basic principles of how this disease can kind of affect our organs, either by depositing around the vessels or just depositing around the cells themselves. So they just can't work as well as they should. Yeah, and here it is again, that higher power where we see the little fibrils all building up around the blood vessel. And if you can imagine, if the type of amyloid you have affects your nerve, they can build up in the nerve, causing the nerve to dysfunction, or like I showed, build up in the muscle or the heart muscle, not letting those cells function as well as they should. Okay, I'm sorry about this is a little bit blurry, but as I mentioned, there's up to 17 different proteins that can cause systemic amyloid. So that's amyloid that can deposit in different organs in the body. I went into AL, amyloid light chain amyloid, or the full name monoclonal immunoglobulin light chain amyloid. So that can go into multiple organ systems: heart, kidney, GI tract, liver, peripheral nerves, soft tissue. And there's no rhyme or reason to it, or at least we haven't figured that out yet. In one clinic, I might have 7 patients with light chain amyloidosis, and each patient will have different organs or tissues involved. Someone might come in with a very enlarged tongue and bruising around their eyes and amyloid in their kidney. The next person might come in with no kind of skin involvement or tongue involvement, but loads of amyloid in their heart and kidney. The next person might come in with amyloid just in their liver and their nerves. It's hugely variable. Another form can be heavy chain amyloid. I have to say, I do not see much of this. It's very rare. We briefly mentioned before serum amyloid A, or what we call AA amyloid. This is related to chronic inflammatory conditions. So thankfully, we don't see as much of it as we used to because we're able to control chronic inflammation better with disease modifying drugs now. But we still see it in some patients where they have long-term chronic inflammatory conditions. And this can build up in the kidneys, in the liver, in the GI tract, and sometimes even the heart. Wild type TTR, so that's ATTR amyloidosis that I went into. And when it's wild type, it means there's no genetic mutation. It occurs in the wild. This used to be called senile systemic amyloidosis, but thankfully, over 10 years ago, we had a rethink of the names because I've seen people with this disease even in their 50s. So we do think it's associated with aging, but people as young as their 50s can develop this. So wild type amyloid, a little bit different to the light chain. We know it really predominantly affects the heart. And that's when we start to get concerned when we see cardiac involvement. It can also, as I mentioned, involve the tendons and ligaments. But for example, some people where they have carpal tunnel syndrome, we might send off their carpal tunnel for evaluation to see if there's amyloid in there. And we might find amyloid in there, but just because there's amyloid in there doesn't mean that it's also in their heart. We have to do the kind of heart testing to see if it's in their heart as well. We just think, and some patients, if we don't see it in their heart, well, then we think maybe you're at risk of getting it in your heart in years to come, and we just need to follow you over time. Okay, then we have an TTR amyloid that's due to a genetic mutation. So we can call this mutant ATTR. Sometimes we call it hereditary ATTR, genetic ATTR, variant ATTR. So there's a single mutation in the TTR gene that makes it more prone to this breaking up and misfolding and making the amyloid. In this case, it can affect the nerves or the heart or both. And that can be very variable for some people. Some people can really mainly have involvement of the nervous system, and some people can really just have involvement of the heart. And that has to be evaluated. Depending on the type of genetic mutation, where in the world that genetic mutation arose from, and different other like family patterns and things like that. Then in this table, the types of amyloid we see, we really don't even see a lot of in our specialized clinic. There's LECT2 protein causing ALECT2. And again, this involves mainly the liver and the kidneys. We've beta-2 microglobulin amyloidosis. This used to be associated with dialysis, and it was mainly associated with the old types of fluid that they used in dialysis. So we see less and less of this. but we can still see some cases or genetic forms of this. We've fibrogen amyloidosis, we've Gelsellin amyloid that can involve the cranial nerves of the cornea, and lysosome amyloid. So again, these are quite rare forms of amyloidosis. And really the main types of amyloid that I see are TTR and AL. And really that's because I'm a cardiologist, so they're the main ones that affect the heart. So here's an echocardiogram of the heart. So this is the left ventricle, the right ventricle we can kind of see a little bit of, and the atria. So amyloid can involve all parts of the heart. Mainly where we kind of can clearly visualize it is in the left ventricle, because that clearly becomes thicker. So this is the wall, the muscle of the left ventricle, and this is actually quite a lot thicker than what a normal heart would look like. And the main root causes we see of cardiac amyloidosis are TTR, either the wild type or the variant form, and light chain amyloid. Some cases we do see the AA or apolipoprotein A1 or apolipoprotein A4 or beta 2 microglobulin. So kind of saying that when you come to our clinic and we say, oh, we think you've cardiac amyloidosis, or we think you've amyloid in your kidney, why we have to delve in so deep is because we have to figure out what protein is causing it. And when I go into the kind of principles of treatment, you see why that's so important. So, as I mentioned, the amyloid can build up, here's a little amyloid fibril, anywhere throughout the heart. So in the muscle walls, in the atria, even along the valves, causing them to thicken. So it can cause heart failure. As the amyloid fibrils build up, like I said, the walls become thicker and they become stiffer. As I mentioned, those muscle cells can't stretch and relax as well as they should. And usually first in the heart, we see poor relaxation. So we just see a stiffer left ventricle, a stiffer heart muscle, which makes you more prone to heart failure, which is just fluid retention, and shortness of breath, ankle swelling, abdominal swelling, symptoms like that, exercise intolerance. Atrial fibrillation or other atrial arrhythmias like atrial flutter are really common because the amyloid can build up in the atria, disrupting the electrics in there and causing atrial fibrillation. Now, atrial fibrillation is incredibly common in many forms of heart disease. So sometimes even just having a stiffer ventricle and the back pressure that causes on the atria can also make you more prone to atrial fibrillation. We also see thromboembolic events, which essentially is strokes. Clots can build up in the heart and go to different parts of the body. We get most concerned when they kind of build up here and shoot off into the aorta and go into the brain and cause a stroke. So that's one of our big concerns, especially you're predisposed to this if you have atrial fibrillation. So that's why anticoagulation can be really key to prevent stroke. Our heart is a very electrical organ. So the electrics of the heart kind of travel within the heart muscle walls. And if you imagine you've got your amyloid fibrils building up in there, and like I said, they can disrupt the electrics in the atria. They can also disrupt the electrical pathways as they travel all through the heart. So you get conduction system disease. So that's the conduction system is the electrical system of the heart, which can be disrupted. And if that becomes quite marked and it delays the speed the electricity like travels from A to B to C to D, we can see bradycardia, so very slow heart rate. And we can see on the ECG that it's taking longer for the electricity to travel from one part of the heart to another, which may mean that you need a pacemaker to kind of take over the electrical pacing of the heart. Chronotropic incompetence means that the heart rate can be blunted. So that can be, when you go to exercise, instead of your heart rate going up to like 120, 130 beats per minute, it stays stuck at like 70 or 80 beats per minute. So you want to work harder, but your heart's just not beating any faster. So that can really limit how much you can do. So that can be one of the ways that amyloid can affect the heart. And this is it. For different people, someone might just have AFib and no heart failure. Someone might have heart failure and no atrial fibrillation. Someone might just have the conduction system disease and no heart failure or AFib, or you might have the whole kind of gamut of things. Again, it can just be variable on how different people's hearts respond to the amyloid buildup within the heart. Syncope means a faint, and that can happen from the heart or because blood pressure goes quite low, and low blood pressure can be very common in this disease. Luckily, we don't see too much sudden cardiac death where the heart just goes into an abnormal rhythm or stops beating. And then some people will definitely present with angina or angina, chest pain or chest discomfort. And like I said, when we showed that original picture of the amyloid building up around the blood vessel, if you can imagine if your heart's trying to pump harder, but you've got this amyloid around your blood vessels, your heart mightn't get as much oxygen as it needs, and that can cause chest pain. Okay, I'm going to take a little bit of time on this diagram to go into not just the heart, because I'm a cardiologist. So, like I said, I'm very biased towards the heart, but amyloid can involve multiple different organs in the body. So, we have the brain. This is one thing that gets a little bit confusing, I think, because sometimes the first time we've ever heard of amyloid is people say, oh, amyloid plaques, isn't that Alzheimer's disease? And there's different ways you could define it, like as a form of localized amyloid, but that's really just a different type of protein in the brain that forms amyloid. So it's not related to the systemic forms of amyloid that I've been discussing. So we don't clearly see a dementia risk related to the other forms of amyloid. So it's not something you have to say, oh, because I've got amyloid building up in my heart or my kidneys, I'm at risk of getting Alzheimer's disease later in life. There isn't a clear association there. Okay, the skin. So my pointer's a little bit off. Amyloid in light chain amyloid can build up in the skin and it can make you really prone to bruising. For example, you can get just a spontaneous black eye or notice that you like rub your hand and you get a huge bruise. Sometimes if we put on the ECG sticker and you take it off and you get a big bruise. What makes this also a bit complicated is the fact that a lot of people are on anticoagulation because they have atrial fibrillations, and that also just makes you prone to bruising as well. The larynx is what controls our voice, and definitely in light chain amyloidosis, people can notice changes in their voice and get a more hoarse voice. The heart we've gone into already. Arteries, like I said, it can involve the arteries, and definitely one of the factors that I don't think we understand all that well, and I think there's multiple components to it, is why the blood pressure starts to go low when you get this disease. So some people might have been on high blood pressure tablets for a while and then notice that their blood pressure is getting really low, or that situation when you go from sitting to standing and you feel very lightheaded. And that can be because of a blunted blood pressure response. And there can be multiple components involving the arteries, the heart, or the nerves. And for different people, it can be different facets of this involvement that can be contributing to their low blood pressure. As I mentioned, in some people, it can involve the muscles, but that's what's, I think, always hard for us as a doctor. A lot of people will come to me and say, oh man, I feel it's my muscles that are slowing me down. They're just a lot weaker. I just can't do what I used to do when I'm trying to go out for a walk or climb the stairs. And to be totally honest with you, we don't understand. And that's why that's one of my research projects. Is the amyloid actually in your muscle? Or is it the fact that maybe your heart just can't keep up with the demand on your muscle? So we're not getting enough oxygen to your muscle to allow it to be able to kind of sprint up and down the stairs or keep walking for a long amount of time. Amyloid can get into the liver, and we see this frequently enough in light chain amyloidosis where people can get a very enlarged liver. And sometimes it can happen that the liver is very enlarged, but it's not actually altering the function of the liver all that much. So your liver is still able to function, although it's very full of amyloid. Unfortunately, sometimes this can predispose you to getting fluid buildup in your abdominal cavity called ascites. And that ascites, sometimes it's very hard to remove by just using diuretics, and you might need to get it tapped where we put in a drain and drain out the fluid from the abdominal cavity. It can involve the gallbladder. definitely in light chain amyloidosis, we can see this. A lot of people might have been diagnosed with gallstones or gallbladder problems way before, before they were diagnosed with light chain amyloidosis. We can see the kidneys are involved at times, and this can be more so in light chain amyloidosis. But again, I think this is a little bit of an element of where kind of it can be really hard for us as doctors to decipher what organ is being involved or what's being affected. And in TTR amyloid or AL amyloid that affects the heart, or any form of amyloid that affects the heart, we can often see kidney dysfunction. So what we're often seeing here is the heart is just not pumping as efficiently as it should. And there's such a strong relationship between the heart and the kidneys. So what we notice is the kidneys have all these different receptors. So if they sense they're not getting as much blood, kind of the alarm bells start to go off in the kidney. So the kidney starts to send out all these different protein chemicals signals to say, I'm going to retain fluid. That's going to help me get more blood flow if I retain fluid. I'm going to try and get the blood pressure to go higher. I'm going to send out signals that will do that. I'm going to send signals to the heart to work a bit harder. And often a lot of the medications we use are to kind of break the signal between the heart and kidney, because we don't want the kidney to kind of work too hard if it's not getting enough blood flow from the heart. Or that's what can happen. The kidney function can just suffer because it's not getting enough blood flow from the heart. And we call that cardiorenal syndrome. So a lot of people might notice that their kidney function is deteriorating and they say, oh, is the amyloid in my kidney? And a lot of the time, it's not actually the amyloid directly in the kidney. It's just the effect of the amyloid in the heart is having on the kidney because it's not getting enough blood flow. And like I said, a lot of the medications we give are to kind of break the abnormal signals that the kidney is setting off. And a lot of that is to do with fluid retention. So that's why we give a lot of diuretics, because we want to say, hey, kidneys, stop retaining fluid, get rid of that fluid. We don't need it. We don't need extra fluid. So I think the kidney heart relationship is quite complex, and they're all complex organs. So kind of sometimes saying, is the amyloid affecting my kidney, or is it just the effect of the amyloid in my heart on the kidney? And deciphering that can kind of be a key element to understanding the disease. Because when amyloid itself involves the kidney, sometimes it actually makes the kidney more prone to losing different types of protein. And again, making you more prone to fluid retention. The intestines. So this is another aspect where we've got two components going on in the GI tract. So sometimes the amyloid can be directly in the GI tract. And if it's directly in the GI tract, you can imagine you just can't absorb the nutrients in your system as well. So a lot of people might notice they're losing weight, they're having diarrhea or constipation. And they have a lot of like GI issues. So sometimes it might not be directly because of amyloid in the gut. Sometimes it can be because of fluid retention. And like I was saying, if there's back pressure from the heart being stiff, fluid can build up in your abdomen and actually can cause the gut to become quite swollen. So if you've got a swollen gut wall, a swollen like intestinal wall, again, that mightn't absorb your medications or absorb nutrients from food as well. So sometimes it might not directly be the amyloid in the gut wall. It might be just kind of due to swelling of the gut wall. The only way we can ever know is to do biopsies, but a lot of the time we'd say it's not worth the risk of the biopsy. For general principles, like we kind of manage these all the same way. Then I'm going to skip the bladder. I'm going to come back to that, but the autonomic nerves. So our autonomic nervous system, as I mentioned earlier, is that flight or fight response. So it's kind of the nerve system that we've no control over. That when I get a fright, my heart rate goes up, my blood pressure goes up. So again, this is huge control also over our gut function. So in some patients, they might have autonomic nervous system involvement. So the amyloid is in the autonomic nervous system. So the gut feedback isn't as good. Usually when we start to chew our food, our mouth creates saliva, it sends signals chewing alone sends signals to our stomach to start producing enzymes, and then once the food is in our stomach, it sends signals to our gut to start that movement to help the food travel through. And a lot of this can be blunted if you've got autonomic system involvement. So you can end up feeling very full very quickly. Again, constipation, diarrhea can be part of that. So for some people, it can be clearly because the nerves to the gut aren't working, or like I mentioned before, it could just be because the gut itself is swollen. Okay, back to the bladder. We definitely can see amyloid in the bladder. And this is kind of another point I wanted to make. Sometimes we can go and do biopsies of multiple organs, or you might be sent for another procedure and they might take a sample and say there's also amyloid in there. For example, a good few patients I look after have had a cystoscopy and a sample's been taken from the bladder and they say, oh, they found amyloid in there. And I kind of say, interesting. You know, the amyloid, and sometimes we can find it and it mightn't be having that much effect on the organ. It's just kind of there in the organ wall. And it's kind of hard to capture how much effect that is actually having on the organ function, or is it just happen to be a little bit of amyloid there? Okay, peripheral nervous system we went into, that can be involved in certain types of genetic ATTR amyloidosis, and also can happen to be involved in AL amyloidosis in some cases, causing numbness and weakness. The stomach is very much related to the intestines. The bone marrow, well, that's kind of where the plasma cells in AL amyloidosis, the problem kind of arises from. There mightn't be amyloid in there. Sometimes we do see it, but it's not the amyloid isn't in there. It's the plasma cell that's the problem. The spleen can be involved in AL amyloidosis. The lungs can be involved, and again, this is an interesting one. If we think probably there is lung involvement in different forms of amyloid, but often we're more concerned with the cardiac involvement. So, you know, if you say, oh, I'm short of breath, could it be my heart or my lungs? Well, we say, look, once your heart's involved, that's the organ that we really want to kind of help, see if we can help the most. And yes, your lungs may or may not be involved, but there's not a lot of ways we can kind of address the amyloid buildup in the lungs beyond trying to stop it getting worse. So that's kind of a kind of tour through the body and the organs and how amyloid affect it. So the kind of overall message is sometimes that organ can be directly involved, or sometimes it can just be a knock-on effect of how another organ that is involved influences the function, exactly like the heart and kidneys and how they influence each other's function. So to get into diagnostic workup, that really depends on presentation. So just want to make sure I'm leaving enough time for questions. So again, this relates to the organ involvement, and often there can be a lot of delays because you can just present sometimes with just fatigue, exercise intolerance. So a lot of the time, as we see in this diagram, the cardiologist is kind of the first port of call, but also can be other kind of primary care, nephrologist, hematologist. And as you see by this diagram, some people can have a steady proportion can have seen more than 10 doctors before someone thinks of amyloidosis. And there can be, unfortunately, still a lot of misdiagnosis. I have such a long list that I've seen people diagnosed with before the diagnosis of amyloidosis. Depression, thyroid dysfunction, vitamin deficiencies, all types of irritable bowel syndrome, all types of stuff before someone thinks of the amyloid. So for diagnosis, down here in very small print, for the most part, biopsy still is key. So it's seeing those amyloid fibrils that I showed you on the biopsy samples at the start that is key to making the diagnosis. In some situations in TTR amyloidosis, we don't need a biopsy and we can make the diagnosis without a biopsy. But that's just in certain circumstances in TTR amyloid. Okay, so again, my bias as a cardiologist. This is an echocardiogram. So you saw this kind of picture before of the left ventricle. This is just the left ventricle at a different angle. So here we see the wall. the walls of the heart, and they're, again, very thickened. And this is kind of an example of the heart. This is definitely a stiffer heart that's got amyloid in the muscle wall. And often when patients present with shortness of breath, exercise intolerance, you might think, okay, we'll do an echo and see what's going on. And that's often the first clue that this could be amyloid, because we see typical features on echo, such as increased wall thickness. Okay. Like I said, biopsy is gold standard. So there's two components to this. This is a biopsy sample, and we use a stain called Congo red stain, and we look at it under a special light where it lights up apple green under a special light. So we see this apple green appearance. That just identifies amyloid. It doesn't tell us what the precursor protein is. So this can be key in your diagnosis. If you have a biopsy and they say, oh, we saw amyloid. Well, yeah, but as we've learned so far today, there's lots of different proteins that can cause it. So the second point to the biopsy is we have to identify the precursor protein. What protein is misfolding and making the amyloid? And sometimes that can be very challenging. We have different stains that we can use in the pathology lab, but even at our center, we have to send samples out to the Mayo Clinic to do something called mass spectrometry. And there's only a few centers in the US who can do mass spectrometry. So sometimes it can take several weeks for us to get an answer on the exact type of amyloid that's in there. And we have to be sure, because the principles of treatment are addressing that amyloid. Okay, I'm going to try and, as I said, keep on track. As I mentioned, some cases we don't need a tissue biopsy, so we don't need to see it under the microscope. And this is mainly in transthyretin amyloidosis. And in this case, we can use a nuclear scan. And here's examples of patients with nuclear scans. And what we're looking for is, this is the heart here. We're looking for uptake of a radio tracer in the heart. So we can use, it's usually PYP is the name of the tracer. So these can be called, sometimes we'll ask you, have you had nuclear imaging, or if you had an amyloid scan, or if you had a bone scan? And why we still call it a bone scan was this was actually a happy coincidence. Back in the 70s and 80s, people said, oh, a person had a bone scan, but why did because these tracers were designed to stick to the bone. And here we see, like, they're in the ribs, they're in the sternum, in the clavicles, and in the shoulder bones. But then the whole question was, why in some people is the tracer in the heart? And we still don't understand why it happens, but we know that it happens in TTR amyloidosis. It can happen in other forms of amyloid. So that's why even sometimes if you have the scan, if we're not certain that it's TTR, we still may need to do a biopsy, because the biopsy is the gold standard, the best way to prove it. But if there's no kind of concern for another form of amyloid, we'll say, okay, the bone scan or the cardiac scintigraphy or the nuclear scan showed uptake in the myocardium. We can be pretty certain this is amyloid. And for the most part, what we're trying to rule out is the light chains being abnormal, because this is the most other reason we see uptake is if it's light chain amyloidosis. So for people, if we do the bloods and we see abnormal light chains, when we look at the blood samples and urine samples, that's when we have to do the biopsy. We can also do a genetic test then for TTR to see if it's wild type or variant ATTR. And that's the same if we're concerned about neuropathy. So if someone has very, very typical neuropathy for amyloid and we do the genetic test, that's enough to make the diagnosis. We don't need a nerve biopsy, because that can be very invasive. Okay, so in the last few minutes, I'm going to go through treatment principles. And as I said, I wanted to kind of get into the basics of this, and there's loads of other webinars available on the ARC website, arci.org/webinars, where you can get into more nitty-gritty of this. So the principles are addressing the precursor protein. That's why we get so into identifying what protein is causing the amyloid, because that's the way we have to treat it. Can we shut that protein down or stabilize that protein to stop it misfolding and making the amyloid? And then the other component of treatment is supportive management. So trying to help your heart, your kidneys, your gut, your nerves as best we can. Okay, Light chain amyloid, as I mentioned, the plasma cells are overproducing kappa or lambda light chain. So we're trying to shut down those plasma cells. This can be done different ways. You can just use high dose melphalan, a chemotherapy, and get rid of the plasma cells. But if we do that, we often have to do a stem cell transplant, which can be pretty invasive and a lot to go through. So we try and avoid that for the most part. And we use other medications, bortezomib, Velcade, and daratumumab, as well as cyclophosphamide and dexamethasone. So they're all to shut down that plasma cell. So if we shut down the production of the light chain, we know we're not making more amyloid. And we also know that those light chains can actually be toxic themselves. So they can just have a toxic effect on the body and on the cells. But it's not getting rid of the amyloid that's already in there. And that's where a lot of the supportive management is key. We do have trials where we're trying to look at antibodies. So we give an antibody to try and stick to the amyloid so your immune system will try and get rid of it. Because at the moment, the immune system, for the most people, doesn't recognize it as a major problem. So it lets it sit there in the heart or in the kidneys and only kind of gets rid of it like very, very slowly or not at all. So this is one of the ongoing trials that we're trying to investigate if these will work. TTR amyloid, same principle. We want to address the protein. So for the most part, we have stabilizers which stabilize the protein and stop it making more amyloid, so it won't build up more in the heart. Or then we also have what we call gene silencers. So these are molecules that interfere with the TTR, not the gene itself, but actually the RNA, so the messenger for the gene. And kind of like I say, it gets rid of the recipe book. So if you cut up the recipe, your cell can't make the protein. So if you can't make the protein levels go down, it can't make the amyloid. So that's another way of treating TTR. Stabilizers are approved for the cardiomyopathy. Gene silencers are approved for variant polyneuropathy. And the FDA are going to make a decision on a gene silencer for cardiomyopathy in the coming months. So there's a lot of changes with the therapies that will be available kind of ongoing and in the coming months. And again, I think there's more webinars that go into detail on those things. A trial at the moment is actually targeting the gene, just getting rid of the TTR gene and seeing if you don't have the TTR gene, again, you won't make the protein and you'll have less, and the amyloid won't build up. So that's a trial that's going on at the moment. And the same for TTR, monoclonal antibodies. Can we give a antibody to stick to the amyloid to help the body get rid of it quicker? So these are ongoing trials in ATTR as well. So for whatever type of amyloid, that's number one, is address the precursor protein. But for the most part, you still have amyloid in your heart or in your kidneys. Sometimes we just got to hope by suppressing the production, maybe things can recover. We see that more in light chain. We don't see that too much. We don't really see it in TTR because most of those medications in TTR amyloidosis just slow down the process rather than completely stopping it. So we have to help manage heart failure. And like I said, that's fluid retention. So that's why we use a lot of diuretics, water pills, loop diuretics, or diuretics called MRAs, like spironolactone or aldactone or eplerenone. I think more and more we're using medications called SGLT2 inhibitors. So that's like Jardiance. I think a lot of people talk about the dancing people in the advert, or Farxiga. And that's mainly to target, like I talked about for quite a while, that relationship between the heart and the kidneys. And to kind of break down some of those abnormal signals that go between the heart and the kidney. Some people, we will think of a transplant, and that's something that we give a lot of thought and consideration to if the heart's in a bad way. Atrial fibrillation, anticoagulation, so blood, sometimes we call them blood thinners, but anticoagulation is the proper word, and that's the key to therapy. So that's your apixaban, Eliquis, rivaroxaban, Xarelto, or Coumadin, warfarin. Amiodarone, we sometimes use to help keep the heart in normal rhythm, or cardioversions or ablations. Conduction system disease, as I mentioned, pacemaker, and sometimes if you have that blunted heart rate response, we may also think of a pacemaker. Like I said, low blood pressure, hypotension can be a major problem. Some people even need tablets to help boost their blood pressure. But for the most part, what we try and do is maybe avoid tablets that will lower your blood pressure, like calcium channel blockers. And sometimes we'll just lower medications like beta blockers or ACE inhibitors or ARBs and avoid other meds that can make your heart rate go too low or your blood pressure go too low. So that's kind of the supportive therapy targets in the heart. And I'm a cardiologist, so that's why I'm biased to the heart. And then that's why you might see several different specialists if you've got amyloid involving multiple organs. So they can all give their kind of expert opinion on how best to manage the organ involved. So kidneys, a lot of time will send you to a nephrologist. For helping with the peripheral and autonomic nervous system, we might send you to a neurologist. The autonomic system, a lot of the time, that's just helping with increasing the blood pressure, and that might be tablets that boost your blood pressure. Carpal tunnel and spinal stenosis, well, sometimes you just need surgery to help with those problems, or just physiotherapy and other things like that. I didn't speak about this too much, but definitely when it builds up in the lungs, we can see fluid in the lung called a pleural effusion. And sometimes you might just need something like a Pleurex catheter or recurrent taps to drain that fluid. The GI system can be really tough to manage those symptoms, really tough. I always say, if I had cures for fatigue and nausea, well, I wouldn't be here. I'd be on some Caribbean island because they are such challenging symptoms to help manage with. People try different diets if they've got a lot of GI upset, like FODMAP diet. Yeah, FODMAP. Some people find that kind of diet, restrictive diet, can help them. And that's what I didn't mention also. If you've got cardiac involvement, we often say a low salt diet. And that's usually, a lot of people will come to me and say, what diet should I do? And for the most part, if it's cardiac involvement, it's a low sodium diet. But otherwise, we don't really understand much about kind of the impact of diet on the disease. When it involves the liver, again, if there's fluid buildup, it can be tapping that fluid. So that was it. That was kind of my 101. So hopefully it was kind of clear and I didn't leave people more confused than what they joined with. But hopefully we'll have enough time to answer any questions if there is any confusion. So I'm going to stop sharing my screen.
I think that went great, Dr. Cuddy. We're getting actually comments in the chat about how much they've appreciated your presentation. One of the questions we had was someone was wondering, how do we know that the drugs are working for us? Is there a blood test? Is there an imaging test? How do you know that the medications are working?
That is a super question. And I think it's one of the questions that I spend a lot of time in clinic trying to answer. So light chain amyloid, it's kind of in some way easy because we can measure the light chains in the blood. And we know when we give those therapies, if the light chains go down, we're success. And we want to see the light chain level go to normal. TTR, it's a lot more challenging. Like I said, we can do a blood test to look at the TTR level. And some drugs the stabilizers might make it go higher. The silencers might make it go lower. But there's so many other things that can affect your TTR level, like nutrition, if you've had a heart failure event, if you've been a bit sick. We see huge fluctuations in that marker. So it's a very hard marker to kind of use on its own to say the drug's working or not working because of all the other outside influences on it. So definitely in TTR amyloid, I use a whole combination of blood tests like NT-proBNP and your kidney blood test, because as I spent ages going into, there's so much effect of your heart and your kidney. That can be a good marker of how you're doing. How much diuretic tablet you need, how you're feeling. Are you more short of breath? What the echo looks like. So really, as cardiologists, we have to use several components to know how the drug is working. And I don't think we have a good answer on it. And I think a lot of research is being done into this because we're going to have more drugs. So it's going to be key to try and understand, if one drug works better than another, when do we swap a drug, or when do we add a drug, or when do we take away a drug? And I don't think anyone has like a kind of easy answer to that question.
Actually, interestingly enough, a couple of questions related to symptoms, asking about itchy skin. Several people have asked about itchy skin, and then about cold, like being very sensitive to cold in their hands.
Yeah. Um, Definitely I have a lot of people who come into me with itchy skin, and it's a toughie. I I I definitely see a lot of it, and that can happen, you know. You can kind of say, okay, I see a lot of it, like people who come into me with nausea and they say, okay, is the amyloid in my gut? And I'm like, I don't know if the amyloid's in your gut or if it's because you've got a bit of edema and your gut's more swollen, or because the nerves that involve your gut are a bit involved. And think it's the same with the skin. Is it the amyloid in your skin? Is it the amyloid in the nerves that go into your skin that are making you more itchy? Is it the medications we have you on? It can be really hard to kind of, for us to kind of parse this all out and kind of say, oh, yeah, I know what it is. So often with the itchiness, it can be a little bit of like trial and error, you know. Did we start a new medication? Should we change that around? Because sometimes the diuretics can cause a lot of itch for people. So it can be a lot of like trial and error to see, will we make some drug changes? Will we send you to a dermatologist, see what they think? So definitely a lot of people I look after complain of itch, and I never have one simple answer for it. It's kind of looking at everyone individually. The cold, yeah, a lot of people say they definitely feel the cold.
Mm.
And definitely people on anticoagulation say, oh, my blood's thinner, I feel colder. Um, Sometimes it can be because your circulation is poor, so your extremities will feel more cold. Or again, could it be that you've some nerve involvement and you might feel more cold?
Also, someone asks, saying that they are really geographically not near a specialized amyloidosis center. So, is it okay for them to be followed by their local? Many times they are followed by their local cardiologist. And what would you suggest in kind of helping make sure that that communication is good and that they're getting the type of treatment they need?
Yeah, I think more and more, especially for TTR amyloidosis, because we're appreciating that it's a lot more common than we used to think it was, more and more kind of heart failure cardiologists or general cardiologists are getting educated about it and are able to manage it. So the one thing you just want to make sure is that the cardiologist looking after you is up to date on what the available treatments are. I always think if you've got AL amyloidosis, it's good to check in with the specialist center, maybe even once a year, because there's a lot more complexities to light chain amyloidosis. And then if you've got the other forms of amyloidosis, definitely worth being seen in a specialist center at least once a year, or even just once when the diagnosis is made.
Someone else is asking if you can have more than one type of
Oh,
amyloid.
yeah, you can. Now, that is rare that you can have more than one type, but we have seen it. And again, that's why we might say, look, some people, light chain abnormality can be very common as you get older, as your kidney function decreases. So sometimes we do the bloods and we'll see a light chain abnormality, but we think everything else fits TTR. And that's why we might say, let's do a biopsy. So it's always, if there's a concern that there could be two things going on, that's when we'll always do the biopsy.
And someone else asked, no, you talked about, but a little bit more about the intestine and how that's involved. They mentioned bloating and amyloidosis. So if you could
Yeah.
just sort of explain that again.
Yeah, bloating is like can be all really common with that because, like I said, this is where it gets complex. It's either the amyloid can just get into your gut wall, which means your gut won't function as well, because that's the whole principle behind it. Anytime amyloid gets into an organ, it just doesn't function as well. Or it can affect the nerves, causing the gut not to move as well, so you can feel more bloated. Or if you've got fluid retention, that can cause fluid retention. Like you might say, some people might feel it in their ankles, but a lot of people actually just feel it in their gut. That they say, no, I don't get swollen ankles, but I notice that I feel really bloated and distended. And it's more that you're retaining fluid in your gut. And when you retain fluid in your gut, it's just like it becomes kind of like a sponge, more sodden. So you feel just bloated.
Thank you. Someone's asking, can atrial fibrillation caused by cardiac amyloidosis be resolved through ablation?
Oh, that's a good question. So we used to kind of say, oh, ablation isn't that successful with for AFib with amyloid. But, you know, their technology is improving a huge amount. So we think maybe with the more advanced technologies that there can be more success with ablation. There's a number of factors that you'll look into. If the atria is very dilated and very stretched, we think the ablation is less likely to be successful. If you've been in atrial fibrillation persistently for many, many years, we don't think it's going to be successful. But if you've atrial fibrillation that is coming and going, then we can think maybe an ablation might help here, and it might help just kind of cut off those abnormal firing electrics and keep you free of AFib. So it's more for people who are going in and out of it, or if it's a new phenomenon that we might refer to for ablation.
And I think we have time maybe for one quick last question. Somebody said, can exercise reduce the NT-proBNP readings?
We don't, to give a really simple answer, we don't officially have an answer to that because I don't think anyone's kind of measured it. So the NT-proBNP and amyloid is kind of, again, kind of multiple things at play here. Because the amyloid getting into your heart itself will cause that NT-proBNP number to go up. But also as the heart's stretched, that can go up. So when people maybe go into AFib or retaining fluid, we can see a jump in the number. So often the main thing that we see brings down the number. In light chain amyloidosis, it's stopping the amyloid buildup, and we can see a really nice decrease in NT-proBNP. Or it's using the diuretics. We can bring that number down as well. If you're retaining fluid, by reducing the amount of fluid retention, there's less stretch of the heart, and we can see that number come down. I don't think we know if exercise can have a big impact on it.
Thank you so much again today for your time. I know we're at the top, just a little past the top of the hour, but it's been a wonderful presentation, and I know I've learned a lot. And I wanted to let people know that, again, this presentation was recorded. It will be available on ARC website, so you can go back and look at it to kind of, if there's something you missed or wanted to know more about, we certainly will have that available probably in a day or so. And we also have our next webinar is coming up March 19th, and that will be on the emotional aspects of the disease. So we encourage you to join us for that. And again, Dr. Cuddy, thank you again for your time. And everybody have a great afternoon.
Super. Thanks again. Bye now.